Our next speaker is Dr. PRASHANT BAWANKULE.
We already had the brief introduction about the wide field imaging and everything. So I would be speaking on why we should have a wide field imaging. Is it just a additional privilege like owning a Mercedes, or is it a necessity in today's day-to-day clinical practice? I will be sharing with you a few of the cases like this. It's not moving here for me. So I think, yeah, this is not there. आप चलता रहे, यहाँ पे नहीं मूव हो रहा है. So I would be sharing with you some of the cases. Well, this already we have spoken about it. I think we will just come to my last part of it. This is what the difference is. Devendra has already said what we see in conventional ETDRS. You see about 75 degrees of retina, and wide field is about 100 degrees, and what you see in ultra wide field is more than 110 to 200 degrees. So this is the difference in what you see at. So let's see, these are the options currently available in market. These are the features which are available with them. I would be not going. So the basic thing is what is wide field OCT? In a wide field OCT, in fact, sir has a bigger version of it. A total, how much is the length of it?
16 or more.
Huh?
16 or more.
No, for us it is 16 millimeter. So, but that is not that big across which we are getting. So in a standard OCT, we have a frame length of about 9 to 12 millimeter, depending upon the machine which you have. But in a wide field which I have, it is about 16 millimeter. So I will just share with you one of the cases. This is a 80 years old mother of a pathologist who had this particular lesion. So if you can see a mount-like lesion where you would like to understand the tissue characterization of this lesion, because at this age you would be always confused whether you have a melanoma or a PCV or what. So we did a wide field OCT for him, and you can actually see the fluid over here, the lesion. You can move it by a bit on the side, and you can see the lesion, and you can understand the lesional characteristic of this on an OCT. And if you can frame it, if you can characterize it, we knew this is a case of peripheral PCV. We decided to treat it with the help of a brolucizumab, which was available to us by then. And then subsequently how it helps is you can see actually the regression of a falling size of or decreasing size subsequently on further injections. And you can see the regression of this disease so beautifully. So this is one of the good uses of ultra wide field OCT. Now, one of the commonest indication is diabetic retinopathy. Let us see how it can help you in also targeted laser therapy. Well, this is the case which came to us treated elsewhere with panretinal photocoagulation. The angioframes which she was carrying was this. Hardly any information. You see some amount of ischemia here, some capillary non-perfusion in periphery in this area. Beyond that, you do not get much of an information. You do an ultra-wide field photograph, you can see there are lesion masks which are scattered, done, not actually a good PRP, we should say. And in fact, when we did an ultra-wide field angiogram, we not only saw the capillary non-perfusion in the posterior pole, also beyond the equator. So what we learned from this disease is, because our classical teaching has been that it is a posterior pole disease, and you need to treat it about 1 to 2 disc diameter away from the vascular arcade up to the equator. That was the standard teaching for panretinal photocoagulation. This whole angiograms of in a diabetic retinopathy in certain cases now challenges that concept that you need to, there might be ischemia ahead of equator, anterior to the equator. And second thing is, treating these areas also would help in reducing the reduction, lead to reduction in the macular edema in certain cases, as well as in neovascularization. Well, this is a case of a retinal vein occlusion. Again, an image from the which we have borrowed it from the patient who was carrying it. Hardly much of an information. And you do an ultra-wide field angiogram for this particular patient, you can actually see the extent of the ischemia, the neovascularization, some telangiectatic vessels in the periphery. So you know actually from where to where you are supposed to do a sectorial laser. Now this is a patient who came with this OCT, which showed he was advised to have a, in the left eye he was advised anti-VEGF injections. Well, when we did a wide field OCT, we could see the sciatic cavities extending much beyond, and so our diagnosis was not, it was not a simple case of macular edema, it was a case of retinoschisis. But why was there sudden gradual decrease in vision in the last few days or last few weeks was the question, and why it should be so cystic. So we wanted to do an fluorescent angiogram for this particular patient. I will directly share with you the angiogram of the right eye, which showed significant macular edema, and you can see the telangiectasia in the periphery with some dropouts over here. So this particular case of a retinoschisis with secondary degenerative cyst in the macula was not necessarily a degenerative cyst secondary to schisis, but it also was being contributed. Some superimposed edema was because of this particular pathology, which we targeted laser, which we did in this area, plus an anti-VEGF was given, and the patient responded beautifully. There was a stabilization at least for a pretty long period of time. Now this is another patient who was diagnosed to have retinal detachment and was advised a vitreous surgery. We also probed into the other eye, and when we looked at it, we thought we are seeing some fibrous tissue in both the eyes. So we decided to do fluorescent angiography, and what you look at is a case of FEVR. So importance is how it changed my diagnosis. Had I not done an angiogram, I would have just bothered about the eye which was already patient was complaining of. But in this case, it drew my attention to the better eye, which was asymptomatic. So now first I treated this eye with the lasers, and once I lasered it, I prevented this particular case from precipitating into a retinal detachment even in the better eye. This is a post-operative photograph of the same patient where we have done a fibrous tissue dissection with a silicone oil imposition. Now this is 52 years old female who had floaters and was advised vitrectomy epiretinal membrane. But on a wide field photograph, I thought there is some straightening of the vessels. So on straightening of the vessels, I decided to probe further, and this was a case of a FEVR with secondary vitreomacular traction, and this is the post-op photograph. So just vitrectomy and ERM peel was not enough. You had to dissect a fibrous tissue which was lying over here, and this is a Ozotrex which we treated to help us out in reduction macular edema fast. Well, this is 48 years old man who complained of and diagnosed as a rot spots in both the eyes. And this is the colored, in fact, a wide field photograph where you can see multiple sclerosed vessels in the periphery. This is an angiogram which can show you nearly 360-degree shutdown. And when we did an angiogram, we could realize it had the same picture was there. Patient had a bilateral carotid disease. So how this is helping me in making bigger diagnosis, I would say. Now this is another gentleman who was diagnosed to have Eales disease, and this was the picture which you saw. And the first time, and with a secondary macular hole. And this is the half zone disease. Half zone disease is usually described in a cases of ROP. We have for the first time described it in a case of elderly male, and that was again secondary to a carotid disease. And so we drew attention to an impending morbid condition, and we could refer him to the physician and help him out in getting a systemic treatment done. Now this is another 26 years old girl who had Mantoux positive. She had healed choroiditis, but she complained of progressive loss of vision. This was not explicable to us. Somehow we did an FAF, we thought all the lesions are healed. We did an angiogram for this patient why she had progressive loss, and we saw an ischemia in the periphery which warranted a laser. Another case of a 48 years male who had healed choroiditis had a bleed. We wanted to do an ultra-wide field angiogram, and we did an ultra-wide field angiogram. You can see the vascular abnormalities quite in periphery which cannot be captured on a standard fundus camera. And so we did a scatter laser in the extreme periphery as demonstrated in this particular patient, and this is how we could achieve and prevent further bleeds. This is interesting case which I always share in various presentations. Diagnosed as Eales disease, combined vascular retinopathy and advised vitreous surgery. Well, fine, we did it. This was the picture. We accept that this eye does need a vitreous surgery. But look at the wide field photograph of the other eye. Do you notice something different in the vessel pattern here? That is called a classic pruning of the blood vessels, which we could pick up. We thought before touching her right eye, obviously which needs a surgery, we decided to do a fluorescent angiogram for her left eye, and this patient was then further systemically investigated, and she turned out to have a Takayasu disease. This is another case, a young girl who had a thusical eye in right eye following a VR surgery for vascular tumor. This history was significant. Father operated for glomus jugulare, grandfather operated for some brain tumor. We didn't have the details. And this was the picture. To the best of the eyes, I think we cannot pick up any lesion in this particular patient. We are all, almost all of us are senior vitreoretinal surgeon. But I was not very happy. I wanted to be sure I'm not missing out something. I did an angiogram. And you can pick out, we could pick out so many vascular tumor lesion, and it was a case of von Hippel-Lindau. And once we did a von Hippel-Lindau, we treated this patient with triple freeze cryo as well as lasers. This is post-op follow-up, which we can do so easily with this. Now the father was asymptomatic, but we decided to investigate. We did an angiogram for him and see what we see on an ultra-wide field is a multiple angiomas even in his eye. Even her asymptomatic brother had these angiomas, multiple angiomas in both the eyes. So is the importance of doing a wide field photography when you see a case of VHL in a child, and you should always try to screen the family members. And this is 1 year later, the brother we wanted to confirm whether the lesions has adequately regressed. To our dismay, there were certain new lesions and few of the lesions previously which had not regressed adequately. And this is how ultra-wide field angiogram helps you in day to day. Finally, we did a genetic study. We could identify the gene, and this is what the recommendation is doing: wide field fluorescent angiography in such cases of vascular tumor yearly. Now, this is another case of a VKH. You can see a silent choroid in such a large wide field OCT. Another case of a wide field OCT, VKH, I will show following this. Again, multiple blisters of VKH, which was again a cover page of one of the journals. This is a girl who was diagnosed to have central Berlin's edema. Obviously, it is a case of a Berlin's edema, means intraretinal edema was there. And this is what we found when we did a wide field photography. So it helps you in completing a diagnosis and making a complete, getting the whole picture together rather than jumping on the diagnosis. A 1 month baby diagnosed to have ROP, and this is what we could achieve in this in a flying baby position. We could not only see the tumor lesion but also the settlings in the vitreous cavity. We could pick it up. Well, this is another thing, triad of leukemia. Rarely do you have all the three features together, and this is one of them. You have a metastasis, you have an infiltration, you have a hot spot, and that is called triad of leukemia. Blunt trauma from a ball diagnosed elsewhere as Berlin's edema. When he came to us, we saw an horseshoe tear. He was not ready, reluctant patient. We showed him a photograph. Well, then he got treated. So this is how this helps us out. Another case diagnosed to have macular edema was advised anti-VEGF over here. And when we did a wide field photography, you can see a subclinical retinal detachment just encroaching the fovea with a horseshoe tear and a beautiful lattice there. So this is how it helps me in changing my diagnosis, or rather convincing. These are other few of the photographs. I will just run through it because of want of time. This is decompression retinopathy. Well, it's not a true color because these are SLO based. And sometimes, as already said, 3D surface to 2D, the sizes of the lesions might be just slightly different. And most importantly, how it changed my practice is that when anyone asks me what is the ROI, this is the return on investment in all this equipment. Besides the fun, besides the satisfaction of having done fully for the particular patient who presents to you. Because in a standard fundus photography, you see only 70 to 80 degrees. While aura to aura is 220 degrees, which is now possible to visualize. So you do not sleep with a feeling that I'm missing something. Probably I might have missed something. Thank you once more.